Welcome to this lecture on structured interpretation of the ocular coherence tomography. The aim of the lecture is to make the right judgment while scanning an OCT scan, understanding the importance of an OCT image, identifying change in structure and pathology, and linking visual history and symptoms to the OCT findings. Here you see a histological slice of the retina with a black and white illustration on the bottom. On the top in the histological section, the 10 layers of the retina are seen, and in those 10 layers you see three distinct dark bands. The one at the top is the ganglion cell layer, the other one is the inner nuclear layer, and the last one is the outer nuclear layer. And these on OCT will appear as darker bands, while the lighter bands are the inner plexiform layer and the outer plexiform layer. And these will appear as lighter bands because they have got more reflectivity on the OCT scan. So you can think of the OCT scan like a cake which has been sliced, and you can see the different layers of the cake. Now, if you look at the two most important receptors in the retina, which are the rods and cones, you see that on the outer side, you have got the retinal pigment epithelium, the first layer of the retina, and that has got microvilli, and that's an interdigitation zone between the pigment epithelium and the outer segment of the photoreceptors. So the photoreceptors have rod lamellae or cone lamellae, and these are actually in process of exchanging material with a retinal pigment epithelium. While the inner segment has got two parts, one is the ellipsoid and the other is the myoid part. The ellipsoid part houses all the mitochondria, and it is the powerhouse of the retina, while the myoid zone houses the Golgi apparatus. And then you've got the cell body and the nucleus, and then you've got the axon, and then you've got the cone pedicle where the synapse occurs with the bipolar cells. So now you know where the inner segment, outer segment junction is. So it happens where the ellipsoid layer makes a junction with the outer segment of the rod or cone. So nowadays it is called the ellipsoid layer, and the integrity of this layer on OCT scan is very important, and if this is disturbed, then the visual prognosis of the patient is very poor. Here you can see a normal OCT scan. This is using a sub-source in which you've got visualization of the choroid as well, and we'll discuss or see the different layers of the OCT scan in the next image. Here you see the image has been reversed, so that what you were seeing as black now appears as white. So here you can see these reflective bands are actually, this is the internal limiting membrane over here, this represents the fovea, and the retinal blood vessels are seen as black in this. Now we come on to the different layers of the retina. Here you see this is the retinal nerve fiber layer, which is thick on the nasal side. The second is the ganglion cell layer. Then you've got the inner plexiform layer, and then the inner nuclear layer, which is housing over here. So it looks white. Actually, it is black on a regular OCT scan, which is not a negative scan. So this is the outer plexiform layer, which is looking black over here. Then you've got the outer nuclear layer, then you've got the external limiting membrane, then the ellipsoid zone, and then the retinal pigment epithelium. Here you see Henle's layer, which is present in the central area, and here these are the axons of the cones which are moving to the side. And the reason it is very important, in this layer or this area of the fovea, you can see the bipolar and the ganglion cells are absent, and these axons of the cones, these are spreading in a radial fashion, and these are spaced in such a way that when there is macular edema, it entraps these hard exudate in this area, And here you can see this is an area which sort of harbors cystic spaces very easily. So this is important to understand when you're looking at the OCT scan. Then you've got the outer plexiform layer, which is also called the middle limiting membrane. So if you see on the scan this horizontal hyperreflective band, this represents the outer plexiform layer. It is also called the middle limiting membrane because all the fluid and all the hard exudates collect around this area, which is the middle limiting membrane. Here you can see we've highlighted this middle limiting membrane by enlarging that image. So here you can again see the middle limiting membrane. Here you can see these are the hard exudate which look white because they are obstructing or producing a reflection for the OCT laser which is taking the image. And the interesting thing which you see are these black lines. These are the shadows from these hard exudates which you see. And these are more hard exudates, but you can see mostly they are present in this outer plexiform layer or the middle limiting membrane. Here they has been highlighted. Here you can see small bit of fluid in that area as well. So this is another slice of the OCT scan which is showing a negative image. The important thing to see over here where the cones are slightly more in number and they are more taller, that is the reason the external limiting membrane and the ellipsoid layer which is you're seeing at the black, that tends to arch forward, and it's important not to mistake this as an abnormal feature. This is a patient. You can see an OCT slice, and here you see the first band or the black line you see is the retinal pigment epithelium, and after that you have the subretinal space which you see over here, and this patient has got the subretinal space and it has got fluid in this. This is a negative image OCT slice, and this is a patient who had a retinal detachment which was showing as it was not limited to the posterior pole. If it had been limited to the posterior pole, it would have been a central serous retinopathy. So this is a patient in which you see a subretinal fluid, but it is localized in the central area, and this is the retinal pigment epithelium. So this is patient with central serous retinopathy. The important thing to see in these patients is you can see all the lines going over here. So this is the retinal pigment epithelium. After that, you've got this ellipsoid zone. It is going forward. It does not remain that black. This is the external limiting membrane which is intact all the way. So this patient has got a good visual potential for recovery. Now, if you take and look at the bands, you can see this is the Brooks membrane complex over here. Then you've got the RPE interdigitation zone. Then you've got the rod and cone outer segments. Then you've got the inner outer photoreceptor junction or the ellipsoid layer. And here you've got the inner photoreceptor segments. So these are actually the detailed illustration of all the layers of the retina. On OCT, the layers are much more than the 10 layers which have been described on histopathology. So from outside, you've got the choroid, in which you've got this sattler layer, inner choroid, and the halar layer, which has got the outer choroid. Then if you move from outside to inside, you have the RPE Brooks membrane complex. Then you have the interdigitation zone, where the RPE makes junctions with the photoreceptors. Then you've got this band, first band you see, this is the ellipsoid zone. After that, you have got the myoid zone, and then you've got the external limiting membrane. And as you move inward, you've got this black band, which is the outer nuclear layer, and the Henle's layer is in the subfoveal region. Then you've got the outer plexiform layer. Then you've got the inner nuclear layer of the bipolar cells, inner plexiform layer, and then the ganglion cells. It is sometimes very difficult to differentiate between the ganglion cell and the inner plexiform layer, but there is a sharp differentiation. Then you've got the nerve fiber layer, which is thicker on the nasal side, where there is a papilla macular bundle. Then you've got the internal limiting membrane and pre-retinal space in this area. just to see again the photoreceptor, just to visualize this area, which is the myoid zone and the ellipsoid zone. So you can see the ellipsoid zone houses the mitochondria, which is the powerhouse, and this is the inner segment, outer segment junction, while the myoid zone houses the Golgi apparatus. And this, beyond this, above the myoid zone, you've got the external limiting membrane. So the space between the external limiting membrane and the ellipsoid zone becomes the myoid zone, and the zone outside the ellipsoid zone is the outer segments of the photoreceptors. So the retinal layers, the retina has got some supporting layers in its structure. So the horizontal cells and the Macular cells, which are going to support the retina as a structure so that all the layers do not slice all the way. So the outer limiting membrane, then you've got the outer plexiform layer, inner plexiform layer. So these are three big layers, and these are pegged with Macular cells. And then you've got all these junctions of the rods and cone, bipolar cells and ganglion cell, and horizontally they have been pegged by the amacrine cells as well. So this is the slices of the retina which you see on the normal retina. So you can see the bands. You have got three nuclear bands, and the first is the ganglion cell, second is the bipolar cell, and third is the rods and cone. Actually, the rods and cone have got the biggest part to play in the retina. So they're, and the other important thing is these bipolar cells in the center. These are the first order neurons of the retina, and the ganglion cells are the second order neurons, while all these rods and cone photoreceptors are just transducers which are going to convert light into an electrical signal. And the other important thing, the retina is transparent. The light passes through all these layers and goes on, is absorbed by the RPE, while it's doing so, it is also being absorbed by the rods and cones outer segments where it is being transduced. So this is the retinal framework, which I told, the Macular cells, and then you got the horizontal structures which are holding the retinas together so it does not move outward or inward. Then if we go on to the inner segment, we have the ellipsoid zone and the myoid zone, which is very important to understand and delineate. So you've got this first band, which is the external limiting membrane. In between these are the Golgi apparatus, which you see. This is the myoid zone, while the second line is the ellipsoid zone, which represents the mitochondria of the cones in this area. And outside this, you have got the outer segments of the photoreceptors, which is the interdigitation zone. Outside that, the first line you see is the RPE, and the second line which you see is the Bruch's membrane. So you have to identify and clarify which lines you see so that you are very clear in your interpretation of the OCT. So evaluating OCT images, if you do it by 5-step, it is very easy. You determine the scan quality, then you rate the overall scan profile, you evaluate foveal profile, then you identify if a foveal cut is present, then you carry out structured assessment. You observe alteration of layers, and you identify additional structures in the pre-retinal, epiretinal, intraretinal, subretinal, and sub-RPE layers. Here you can see a qualitative assessment of the retinal layers of the slice. Here you can see this slice is much superior to this slice in which the signal intensity is lower. So you need to identify, and you can see much more clarity of changes in this compared to the picture below. So quality of a scan is of utmost importance if you want to get good results. So the scan quality, you need to identify inner and outer retinal bands, good signal to noise ratio, any truncation or any shadowing which is visible. Vitreous opacities such as asteroid hyalosis can sort of alter the quality of the scan. Here you can see the reflections from the asteroid hyalosis. They are producing shadows and they are causing that retina to be segmented rather than being a continuous structure. This is a patient in which you can see there's foveal elevation in the center, and then the retinal layers are not present in the inner side, and there are strands which are going towards the retinal pigment epithelium, sort of identifying this patient to be of retinoschisis. Then vessel shadowing is a very important phenomenon, and this becomes even more important when you're checking for or using angio-OCT as well. So when there is a vessel, it looks white and then it casts a shadow behind as well. So when you're doing angio-OCT, if you're looking at one blood vessel, you might see it in the next layer. So the machine algorithms tends to cancel those shadows to give you a better view on angio-OCT. So then the step 2 of qualitative assessment is you rate the overall retinal scan profile. The normal overall retinal scan profile has a slightly concave curvature. Abnormal profiles will include exaggerated concavity and convexity of the retinal folds. Here you can see a central concavity which is present in this patient. This is a patient's OCT. The important thing which you see is the scan is the foveal depression is not normal. On the medial side, you see there's an epiretinal membrane which is denting the retina and causing distortion of the retina and thickening of the retina on the nasal side. So you need to check the retinal profile. So here the retinal profile becomes slightly different. Here you can see, if you see this retina, you've got thickening of the retina. There is splitting at the fovea of the inner retinal layers. Then there is these fibrous bands between the different layers of the retina, and there's loss of retinal fibers or details in the temporal side compared to the nasal side. You've got these inner outer nuclear layer, all bands present, while on the outer side there doesn't seem to be any, which signifies this looks like a patient with retinoschisis. Here you can see this is area in which you see the first black band. This is the retinal pigment epithelia if you're looking from behind. And then you've got this whitish line which you see is the subretinal fluid, and there's another one over here. So there are two fluid areas in the subretinal space with intact inner retinal layers. So this is a patient with central serous retinopathy. Then the overall retinal profile would look for an RPE detachment, either if it's a fibrotic, serous, or hemorrhagic, or a retinal detachment which can be rhegmatogenous, serous, or a retinal thingering which can be CSMO or CMO or CNV. Then you go on to qualitative assessment number 3, which is evaluate the foveal profile. The normal fovea has a slight depression in the surface of the retina. Here you can see there is a depression in the retina, and this depression is absent in this patient with an epiretinal membrane which is lifting the foveal umbo upward. And this is an area in which actually instead of elevation of that area of the fovea, you've got a break in the center, and this looks like a lamellar macular hole. So deformations in the foveal profile include the following: macular pucker, macular lamellar hole, macular cyst, and a macular hole. Then assessment of quality, step 4, you identify the foveal cut. In the slice, do you have a foveal cut? That means, is the fovea present in this? The reason it might not be present, that it did not show in the slice which you took, or the second thing is that the retinal foveal has been so distorted that it is difficult to find a foveal cut. So this is a patient with angioid streaks, which you see on fluorescein angiography over here, and you see that in this slice you've got a foveal cut, but there is elevation of the retinal pigment epithelium in the form of pigment epithelial detachment, causing elevation of the foveal contour on the temporal side. And this is another slice, but you do not have a foveal cut over here. So do not see a fovea over here, but similar structures. Here you again see the fovea is present over here. So you need to identify that, because in order to give a report of OCT, you need to tell the structure of the fovea. Then step number 5 of qualitative assessment is you carried out a structural assessment for observe the alteration of layers, and you identify addition of layers in pre-retinal, epiretinal, intraretinal, subretinal, and sub-RPE space. So additional structures which you can see is a macular hole, epiretinal membrane, drusen, blood component, fluid or edema, non-exudative spaces, neovascularization, fibrosis, lipid precipitates, hyperreflective spots, dense areas, tubulations of outer retina, and tumors. So here is a qualitative assessment. So the spaces where you want to look for, this is the pre-retinal space in the vitreous, then you've got the epiretinal space, then you've got the intraretinal space where you've got all the fluid, and subretinal space, especially in patients where you've got macular degeneration or in which you got PCV. So qualitative assessment, pre-retinal vitreous cavity, what can you see in that area? Posterior hyaloid, epiretinal membranes, vitreoretinal strands, vitreoretinal traction, syneresis, pre-retinal neovascular membrane, and prepapillary neovascular membranes, such as NVD. For pre-retinal space, a normal pre-retinal profile is displayed as black or white space. A prepapillary, prefoveal lacunae, or premacular bursa is visible in this patient. This is in swept source OCT or in a regular OCT. If you move the focus forward by pressing the plus button, you can focus or give a good photograph of the vitreous. And this sort of highlights pretty nicely, especially this is showing vitreous separation from the macula. Then you've got intraretinal changes, which can be choroidal neovascularization, diffuse intraretinal edema, cystoid macular edema, hard exudate, scar tissue, and atrophic degeneration. So here you can see fluid present in the intraretinal spaces, which is causing retinal schisis over here. And this is more fluid is present, but this you can see the blood vessels over here, and these are producing shadows in this area. And this is another area in which subretinal neovascularization is invading into the layers of the retina and causing elevated foveal contour. The disease is starting more in the subretinal or in the outer retinal layers. So what to look for? In summary, you need to determine the scan quality, rate the overall scan profile, evaluate foveal profile, identify the foveal cut and carry out structured assessment and observe alteration of layers, identify any addition of layers which can be pre-retinal, epiretinal, intraretinal, subretinal, and sub-RPE. So another important aspect is identifying the terminology of how you will see the retinal pigment epithelium or any of those ellipsoid layer or the outer limiting membrane. You can have the alteration of layers such as irregularity. You can have fragmentation like this. You can have rupture which is missing. Then you can have interruption. Then you can have a depression like this. You can have an elevation. Then you can have thinning of layers or thickening of layers. So if we look at the slide over here, now the two things which are being highlighted are thickening and irregularity of layers. So these are drusen present which are producing irregularity, and along with that there is drusen is producing thickening of the pigment epithelium as well. Then you come on to elevation. So here you come, these are drusenoid PEDs in which you see elevation of the retinal pigment epithelium, and along with that the other layers of the retina. Here you can see there is an interruption of the retinal layers in the center because of foveal atrophy. Then this is fragmentation. So you can see you hardly see any ellipsoid line, but this is the retinal epithelium with the Brooks membrane running, and this seems to be fragmented. Here you can see it is present over here, it's absent, then is present, then is absent. Looks like a dotted line. That is fragmentation. Then you can have rupture in, this is a patient with intraretinal angiomatosis proliferans or RAP, in which you can see this is a rupture of the RIP, RPE RIP, which you're seeing in this patient. Then additional structures, you identify the RPE, examine RPE, examine posterior to the RPE, and then examine anterior to the RPE. So additional structures in RPE you see for irregularity, fragmentation, rupture, interruption, depression, elevation, thinning, and thickening, which we just demonstrated. Posterior to the RPE, you look for any PED, Brooks membrane, hyperreflectivity, atrophy of RPE versus fibrosis, and hyperreflectivity, which can be a screen effect. Then you look for things anterior to the RPE, which can either be in the vitreous, going right in the front, then retinal thickness, foveal depression, subretinal fluid, external limiting membrane, ellipsoid layer, hyperreflective spots, dense areas, outer nuclear layer, intraretinal cyst, and inner retinal layer. Here now we're going to show you a systematic approach of how to read the OCT scan. This is a patient who has got hard exudation present in the posterior pole, but you don't see any hemorrhages, microaneurysm, cotton wool spot as you would see in diabetic retinopathy. So we did an OCT scan, and here you can see the important thing. These whitish lines are seen as whitish lesions. They are present in which layer? They are present in the outer plexiform layer. Here you can see that. And in the Henle's layer, you can see this is a large intraretinal fluid-filled cyst. And these hard exudates are casting shadows at the back. So this was a patient in which, then the next thing which you wanted to see is the retinal pigment epithelium. It needs to be elevated, and there seems to be slight irregularity in this area. And the other important thing, this is the area where this is the external limiting membrane running over here, seems to be slightly disrupted in the center, and then the ellipsoid layer is totally absent in this area. So it was a patient who had a wet AMD associated with exudative leakage, although you do not see that big retinal pigment epithelium, but this was representing that thickening of the area. Then for morphology, you look at overall retinal deformation, retinal profile and interface deformation, and pigment epithelium and outer retinal deformation. For overall retinal deformation, you see concavity in myopia, staphyloма, wide or small. For convexity, if there is subretinal cyst or dome-shaped macula. For retinal profile and interface deformation, you can get horizontal traction, epiretinal membrane, anteroposterior traction, holes, lamellar holes, pseudoholes, retinal folds, while pigment epithelium and outer retinal deformations are seen in PED, drusen, dome-shaped macula, and subretinal cyst. Then structure, microstructure segmentation. Structural alterations produce reflectivity. Structural deformations of the overall retina can happen, inner retina or outer retina. Overall retinal structural deformation will be focal edema, diffuse edema, ischemia, atrophy, and cystoid edema, while inner retinal structure deformation will be focal, diffuse edema, cystoid edema, and atrophy, while barrier structure alterations would be disruption, fragmentation, deformation, layer refractivity modifications, which can happen either in the inner limiting membrane, plexiform layers, ISOS junction, RPE, or plexiform layer, ISOS and RPE, and then you can have loss of structure. So you can have loss of reflectivity, you can have deformation of structure, you can have barrier structure alterations, and you can have loss of structure. These are two very busy slides, but if you get to look at them and study them deeply, I think you will understand a lot of things which are happening in this. Then you come on to reflectivity. Normal reflectivity, as we highlighted before, the highly reflective are the nerve fiber layer, ISOS junction, outer limiting membrane, pigment epithelium, while medium reflectivity is plexiform layer. And low reflectivity is ganglion cell, outer nuclear, inner nuclear layer, photoreceptor, and choroid. Higher refractive in pathogenesis. In high superficial, it can be preretinal, epiretinal membranes. Inner retina, you can have hemorrhages which produce reflectivity. Outer retina, hard exudate and hemorrhages. RPE and choroid, you've got the same neovascular membrane, hemorrhages, hyperplasia, nevus, atrophy, scars, they all produce high reflectivity. Medium reflectivity is produced by lipofucsin, tamoxifen deposits, and low reflectivity is produced by local diffuse edema, which looks like black, and very low optically blank, such as cavity cysts, detachment, and projected shadows. Then you have next thing is a shadow of the screen effect, which can be superficial, intra or subretinal, or deep. So it's of a dense screening, which can be macroaneurysm or a microaneurysm, imperfect screen, hemorrhage, or cottonwool spot. Then you have intraretinal screening. Dense screen would be a hard exudate, retinal deposit, neovascular membrane, which are more opaque things, while an imperfect screen of thinner areas would be a laser spot and hemorrhages, while a deep screen would be RPE, hyperplasia, nevus, and subepithelial parasite cyst. Now we just go through some clinical cases, and then I'll just interpret the cases and go through the findings so that this is a colored picture showing hard exudates. These are hemorrhages. There are some scar marks over here in the foveal region. Dot blot hemorrhages are present. So this is a patient with diabetic maculopathy. On OCT scan, I will comment that this patient has got an elevated foveal contour in which the foveal section cannot be seen. The other thing is the posterior vitreous face is loosely adherent to the posterior to the retina and the macular area, and it is vitreomacular adhesion, and it is not lifting the retina. The next thing which you want to see is there is intraretinal fluid in the intraretinal spaces, and there's a large cystic cavity in the foveal region, making that lifting of the fovea. Next thing, you see that the retinal layers are not very organized. There's disorganization of the layers. You can see the inner nuclear layer of bipolar cells, but the outer plexiform layer is full of hard exudates. You can see these white dots, and then this is quite irregular compared to a smooth line, and you can see it's even disrupted in this area as well. Then you've got the outer nuclear layer, which seems to be pretty disrupted as well. Somewhere it's very thick with fluid, and somewhere it is thin, and somewhere it is normal. Then you want to look for the outer limiting membrane, which seems to be present, but it might be absent. It's not absent. Then you have the ellipsoid layer, and the ellipsoid layer is slightly difficult to see, while the retinal pigment epithelium is quite easy and the choroid is easily visible. So so you would say that this patient has got a diagnosis of elevated or thickening of the retina with intraretinal fluid with vitreomacular adhesions and presence of hard exudates in the outer plexiform layer. This is another patient with similar hard exudate in the lower part. He had an old central retinal vein occlusion, and there are hemorrhages in this area as well. Here again, if you look at the OCT scan, I would say this is a patient showing an OCT scan in which the retinal foveal contour is missing, and there is elevation of the foveal depression. There is vitreomacular adhesion in the center, and there are large cystic spaces in the foveal region, especially as the Henry is there. And then on the outer side of the nasal side, you've got these large hyperreflective areas producing casting shadows. These are the dense hard exudates which you see over here. Then you've got small hard exudate present more on the temporal side. The external limiting membrane is nicely seen, but it's getting fragmented in the center, and the ellipsoid loan is definitely fragmented in the subfoveal region. The RPE seems to be slightly irregular as well. So this patient will improve, but does not have 100% improvement because there is some disruption in the ellipsoid layer in the central area. Now looking at this patient, you can see this was a diabetic patient. These are focal laser scars. These are PRP scars. The reason to show you this picture is that this patient, I would say this patient has got generalized thinning of the foveal layers, and there's diminution of different layers in this area. There's vitreomacular adhesion, and then you got a foveal contour which seems to be of the normal depression, but the main thing, if you look at these layers are very small. The retinal pigment epithelium, the outer nuclear layer is present in the foveal region, but as you go outside, it becomes so thin. The external limiting membrane and the ellipsoid zones starts disrupted or fragmented because these are the laser marks over here. So the laser causes a lot of disruption. Focal laser causes a lot of disruption in patients with diabetic maculopathy. This is a patient with an altered foveal reflex, and if you see on the, I would say that this foveal area is split and there is an irregular area of cavity formation where the central area which is deficient. So this is a patient with a lamellar macular hole. The other important thing you see, the external limiting membrane is intact. The ellipsoid zone seems to be intact with slight fragmentation in the very subfoveal region. So if you do surgery, it might have a slightly better prognosis. This is a patient with full thickness macular hole on the colored fundus photograph, and this is a large hole, probably more than 400 microns, and you cannot see the P vitreous attached to, so it looks like a grade 4 macular hole. So you would say this is a patient in which there is deficient or deficient retina in a circular pattern in the foveal area, and there's thickening of or rolled edges of the retina surrounding it with some intraretinal fluid, which is typically the cuff of fluid which this area of the retina imbibes. Then you can see the external limiting membrane, obviously it is disrupted where there is absent. Then the ellipsoid zone is also absent. The visual prognosis, as you know, macular hole can be variable. So this is a patient in which you can say this OCT shows elevation of the foveal contour, thickening of the retina in the foveal region, temporal to the fovea. There is a hyperreflective area just above. So it says this is more like a lipofucsin type material in which is present just above the RPE and the external limiting membrane, and it is also casting a shadow in this patient. So this was a patient in which the vitreous is pretty clearly being seen. The other important thing which you see is the most obvious thing is if you look at this patient has got an OCT scan in which the foveal depression is present, but there is a slight elevation of the foveal contour temporal to the fovea, and there is elevation of the retinal pigment epithelium with sort of bilobe pattern in the center. And you see the residual white line which you see is the Brooks membrane. The retinal pigment epithelium has been lifted in a pigment epithelial detachment, and the other layers of the retina. This is slight bit of subretinal fluid in the subretinal space over here, and the other ellipsoid and the myoid zone and the external limiting membrane are lifted along with this. So this is a patient of pigment epithelial detachment. This is a very interesting case of Valsalva retinopathy in which you see a subhyaloid hemorrhage. So this is the vitreous phase, and this hemorrhage is actually present between the vitreous and the internal limiting membrane, which is highlighted over here. So this patient would definitely need a hyalodotomy with a YAG laser, or the other option is to go inside and do a vitrectomy and remove that vitreous and release that hemorrhage, and then later on wash that out. This is, you can see the concavity is exaggerated. If you see that concavity is much more. So this is a patient with high myopia. The other thing, the retina gives you a tessellated fundus. The other thing which you see on OCT is you can see this is the inner nuclear layer seems to be okay, but the outer plexiform layer is going slightly haywire. It's thicker in the nasal side, but it is quite thin on this side. And this is the choroidal sort of blood vessels. You do not see a lot of them in these patients. Then this is a patient uncolored fundus photograph. You can see these red lines horizontally and vertically. This is a patient, and this is a greenish area in the center. So this is a patient with subretinal neovascular membrane associated with angioid streak. On OCT, you will say this patient has an elevated foveal contour with thickening of the RPE and a dense subretinal neovascular membrane complex, which is elevating the fovea slightly nasally. There is associated on the temporal side, there is subretinal fluid present temporally. Then if you look at the RPE, that seems to be covered in this lesion, but then you go on to see for the ellipsoid and the external limiting membrane, which both seems to be disrupted. This is the inner nuclear layer. You see this is the foveal cut over here. This is getting disturbed as well in the center. So this patient probably will improve but does not have a very bright outcome. So this is another patient in which of diabetic maculopathy, but this was slightly less in amount. Probably this is probably more of a lipofuxin type material and a sort of a hard exudate type of material. This was not diabetic retinopathy, but of a supratemporal vein occlusion in this area, which we initially thought could be lipofuxin if it is a disease such as vitelliform disease, but it is actually subretinal. In the subretinal space, you've got blood in this area, which will always look white as well. So the important thing is you can easily get confused that is it blood or is it hard exudate, because they all look white because they are refractive. And then you obviously want to look if it is casting any shadow, but you will say this is an OCT showing elevated foveal contour, thickening of the retina, more so on the nasal side. There are some cystic spaces in the handage there in the subfoveal region. The outer plexiform layer nasally seems to be slightly irregular, so this is a patient typically would require anti-VEGF therapy. Then you've got, this is a classic case in which the retinal pigment epithelium and the Bruch's membrane remain intact, but the layers of the retina get elevated and there is subretinal fluid. This is CSR. The external limiting membrane, other layers are all intact, so this has got a good prognosis. The last few slides, I'm showing you an area where there's sort of pigment mottling over here, but strikingly you see the foveal contour is pleasant. The foveal contour is wide in this patient and the central subfoveal area is very thin. The retina is generally thin on the nasal and the lateral side. So this is a patient with dry macular degeneration. So if you want to look, find the outer plexiform layer, it is missing over this layer, the rays of the retina. So that tells you, but the more and there is shadowing of all these thinning of the retina. It produces shadowing, but the choroid vessels are very prominently defined. So in conclusion, know your chorioretinal anatomy, familiarize yourself with normal variation as OCT recording, adopt a systematic approach to evaluating OCT images, familiarize yourself with the etiology of macular disease, and in the end, do not forget vision, sign, symptom, history, and fundus appearance. I hope you've learned something from this lecture and we look forward to seeing you in the future. Thank you very much for watching.